Hi, in this lesson, we will be talking about chapter 22, which talks about drug therapy for gastrointestinal problems. Lesson objectives for this class will be listing common names, actions, usual dosages, and possible side effects and adverse effects of anti-nausea drugs and antiemetic drugs as well. We'll be talking about what to do before and after giving these medications. Um, Explain to patients what to do, what not to do, when to call the doctor. Lifespan consideration. We're also going to be talking about drugs and possible side effects and adverse effects for drugs for anti-diarrhea as well as for constipation, and what to do before and after giving these medications. Explain to the patients what to do, what not to do, and when to call the doctor, and of course, lifespan considerations. So just a quick overview. The functions of your GI system is, of course, to break down food and to absorb nutrients from food as well as eliminating the waste from the food that we ate. Um, your gastrointestinal system begins through your from your mouth all the way up, all the way down to your anus. We all know that the small bowel is where the parts of our digested food are usually absorbed, and the large bowel, which is your colon, processes the waste and absorbs the fluids, and the rectum is the one that eliminates the food out of your digested food, and where the stools are stored for bowel movement. This is just a quick anatomy of your gastrointestinal system. It goes all the way from your mouth, goes to your large intestines, and all the way small intestines, large intestines, and then down to your rectum and anus for expulsion. So this is how the stools in your small bowel going to your large bowel. So solid waste comes from your um, small intestines, connects to your large intestines. This is where water is being reabsorbed to your body, and this is where the stools are formed. And again, rectum and anus. So we'll talk about nausea and vomiting. So nausea and vomiting are defenses of your GI system and are signs of altered body function. Nausea is an unpleasant sensation of the need to vomit, and then vomiting, of course, after the nausea, is the forceful expulsion of gastric content through your esophagus out through your mouth. So the process of vomiting consists of three phases. You have your nausea, your retching, and then the vomiting. Retching is like the dry heaving. It's like you have the feeling that something is going to come out. Um, when a balance or sense of position is upset, vomiting can occur. The vomiting center of your body is located in the medulla and is responsible for initiating the vomiting reflex. This is the vomit center. We talk about antiemetic drugs. So how does this work? Antiemetic drugs control nausea and prevent vomiting. So nausea and vomiting often occur together, and the same drugs are used for both problems. So you have your phenothiazine, anticholinergics, antihistamines, 5-HT3 receptor antagonist, and dopamine receptor agonist. So each drug affects different receptors, and some drugs affect several sites. We talk about phenothiazines. Um, they block the dopamine receptor in the chemotrigger zone of your brain, and this actually inhibits one or more of the vomiting reflex pathways. So this also has a sedating effect, which helps control the sensation of nausea. And then your anticholinergic are drugs that inhibit other pathways of the vomiting reflex. So the intended response for these drugs is to inhibit or disrupt vomiting reflex pathways. Um, the patient again will be sedated possibly, and nausea is relieved, and then vomiting is prevented. Because if you're sedated, there's no way for you to vomit, or if your nausea is controlled, vomiting will not happen. Side effects, it varies on the type of medication you take. It could extend from insomnia, double vision, tinnitus, hypertension, photosensitivity, and EKG or ECG changes. Adverse effects again depends on what type of drug you have taken. It could be neuroleptic malignant syndrome, it could be a coma, seizures, tardive dyskinesia, neutropenia, and respiratory depression. So to administer antiemetics, you, of course, before giving this drug, you have to know their baseline vital signs, level of consciousness, weight, and electrolyte levels. You have to also assess for bowel sounds and see if there's any abdominal distension. Obtain a complete list of drugs of the patient that he or she is currently taking, so you would know if there's any kind of interaction that could occur. After giving these drugs, of course, you have to monitor any more episodes of nausea or vomiting, vital signs, daily weights, of course, and status of the abdomen. You have to immediately report any signs of respiratory depression to the doctor because this could be an emergency. And watch for signs or the side effects or adverse effects of the drug. So teaching your patient, you have to be caution your patient about driving or operating heavy machineries because this drugs can sedate them, as we talked about earlier. You have to instruct them to use sunscreen for possible photosensitivity that could occur, wear protective clothing, and avoid tanning beds. Teach the patient about the signs and symptoms of malignant neuroleptic syndrome and tardive dyskinesia. So tardive dyskinesia can extend from Parkinsonian-like syndrome. Tell your patient about eating foods that will increase the bulk and about the importance of drinking enough fluids because drinking enough fluids is the one that will prevent them constipation. So it's very, very important. And then lifespan considerations. So children may have muscle spasms of the jaw, neck, and back, along with jerky movements of the head and face, as well as balance disturbance if they take and are possibly taking antiemetics. You have to consult the doctor for pregnancy and lactation when it comes to these drugs and avoid these drugs while breastfeeding. And older adults may more likely to experience side effects of confusion and dizziness while taking this drug. Shaking hands and balance disturbance could be related to tardive dyskinesia. So just a quick recap, when we talked about the phenothiazine, this includes your promethazine or your Phenergan. This also includes your compazine or prochlorperazine. And then, so those are the two phenothiazine drugs that was discussed. Now we talk about constipation. So constipation, this is not a this is just a symptom. This is not a disease. This is not this could be a reason of a pre-existing condition, or this could be a result of an existing condition. This is considered constipation is considered if a patient is having under 3 bowel movements per week, because technically bowel movements should happen at least once a day. Stools are very hard, very difficult to eliminate. It can be very small pieces and dry, and it's hard to pass out. Bowel movements can be very painful when it comes to this. When it comes to constipation, it can even lead to rectal bleeding. Common causes of constipation include low fiber in your diet, lack of physical activity, they're not drinking enough fluid, delaying going to the bathroom, and misuse of laxatives. And there are drugs that can definitely affect nerve activity in the colon fluids, particularly opiates. So this is how constipation occurs. So once liquid stools or liquid intestinal contents enters from the small intestine to your large intestine, we know that your large intestine is the one that removes the fluid for it, there's reabsorption. And then if there's enough fluid, if there is not enough fluid to be eliminated or to be removed, your body will still remove the fluid that it needs to be removed. However, what will happen is that your stool will not have enough fluid for expulsion. It can get stuck on the walls of your large colon. And then as it goes through, again, fluid still remains to be eliminated. That's why you have this very dry stools that will be left So these are the types of drugs that we use to treat constipation. You have your bulk forming laxatives, you have your stool softeners, lubricants, saline laxatives, and stimulant laxatives. So the intended response for this group of medication is, of course, to soften and pass the stool. So if your stool is softer, it will be easier to pass, to relieve and prevent constipation, of course. Side effects, again, varies with the drug type. It could be diarrhea, skin rash, stomach cramping, abdominal distension, nausea, gas, and headache, as well as reflux. Please know that these drugs for constipation must only be used for a short period of time unless otherwise indicated by your doctor. Adverse effects can send to severe and life-threatening. Um, the xylem and docusate may cause allergic reactions. So before giving this drug, you have to review the patient's medications, know their current bowel habits, abdominal distension, you have to assess that as well for bowel sounds, and get your baseline vital signs. Prepare at least 6 ounces of fluid to be given with this oral medications. So it helps, again, increasing the fluid intake of your patient. After giving these medications, you have to recheck the patient's abdomen for distension and bowel sounds, and monitor bowel movements to assess the quality of the stools that they're passing and to see if the medication is actually working. You have to teach your patient to drink at least 8 ounces of fluids unless otherwise they're on fluid restriction. However, increased fluid intake is definitely helpful for patients with constipation. Keep a daily record of their bowel movements. Teach your patient to drink at least 1,500 to 2,000 ml of fluid every day. Remind the patients that most laxatives should be used only for short term. And teach your patient not to take oral forms of these drugs within an hour of taking an antacid because it can prevent absorption of it. So lifespan considerations, you usually give children half of the usual dosage of this medication. It should not be given without specific instructions from the doctor, and possibly consult pediatrician if necessary. Pregnancy and breastfeeding. Most drugs are safe. Prescriber must assess the benefits of this before giving it to the pregnant mother. For older patients, often use laxatives for a longer period and higher dosage, which places them more at risk for diarrhea and fluid imbalance. Take note that if patients for constipation, that definitely side effect of that would be diarrhea, especially by Sacodil because it's an expulsion. You have to know that if you give this medication, assess them for any signs of electrolyte imbalance, particularly potassium, because potassium is expelled through the stools, and hypokalemia is a life-threatening condition. Now we talk about diarrhea. So this is not, again, a disease, but a symptom. It can cause dehydration rapidly in infants and children. It can be acute or life-threatening due to electrolyte imbalance, like we talked about earlier, particularly the potassium. Imbalance between the absorption and secretion functions of the intestine can lead to diarrhea. And the most common cause is inflammation of the small bowel. This is how diarrhea works. We know that normally fluid is reabsorbed from in your large colon, reabsorbed back to your body. However, with inflammation, since it has your body is trying to adapt to it, water is not being expelled enough. Therefore, there's so much more water left in your large colon that's causing the diarrhea. Most cases of infectious diarrhea are caused by viruses or bacteria and contaminated food or water. You have your cholera, it could be amoebiasis or any kind of bacteria, or even parasitic as well. Many drugs can cause diarrhea. Four types of this is the four types of diarrhea. You have your osmotic, you have a secretory, exudative, and motility disorder. So when we talked about the osmotic diarrhea, this is usually caused by lactose deficiency or magnesium or antacid excession or excessive magnesium and antacid. We talk about secretory. It could be related to E. coli infections and ileal resection or even thyroid cancer. Exudative, it could be related to ulcerative colitis or Crohn's disease or shigellosis or leukemia. And motility disorder can be related to irritable bowel syndrome or diabetic neuropathy. Drugs for diarrhea, you have your anti-motility, absorbent and adsorbent, and anti-secretory. So anti-motility includes your loperamide or Imodium. This medications correct any underlying problems and help the body control the diarrhea and its uncomfortable symptoms. Intended response is for GI motility and diarrhea to be decreased. Fluid from bowel is reabsorbed and excretion of fluids decrease and activity of the bacteria is also decreased. Not all diarrhea is bad. Know that you have your condition called Clostridium difficile or C. diff infection. Majority of the time, diarrhea is the most common symptoms of C. diff, and there are also times that you have to let the patient move their bowels because continuation, if you give them anti-motility drugs, the bacteria will just remain in their colon, which can cause possible systemic complications. Side effects and adverse effects of antidiarrheal drugs. Of course, you have since you're giving them anti-motility, the possibility of constipation is also high. This is usually uncommon in healthy adults. It varies by drugs. So adverse effects could be intestinal obstruction since you're giving them medications to stop or to decrease their motility or their peristalsis. Toxic megacolon is definitely potentially life-threatening. This is where stools is collected in your large colon that causes, so this, let's say for example, this is a large colon. What happens is stool gets collected and it can become enlarged. And then once it becomes enlarged, it can get stuck and pushes through the walls of your intestine, and it can cause necrosis and possibly burst out. Other adverse effects could be fever, abdominal pain, tachycardia, and dehydration. So this is how toxic megacolon looks like. So this is, if you can see this large bulk of stool that's left in there, that's where the stool is collected. It's not hard. It's very, very hard to pass, and it can push through the abdomen and create decreased perfusion in the walls of your intestine, which again weakens it and possibly burst out of it. This is how a patient with toxic megacolon looks like. You see the abdominal distension. There are also times that their bowel sounds are very hypoactive to absent. So to give these antidiarrheal drugs, you have to know the complete drug list of your patient, know their baseline weight and vital signs, assess their abdomen, skin turgor for dehydration. After giving this drug, you have to reassess their abdomen for bowel sounds and distension, and watch for signs of toxic megacolon. Monitor the vital signs for diarrhea, stools, and skin turgor as well to see if the medication is working. You have to teach your patient to take this drug exactly as prescribed and never double dose. This may cause severe constipation. Avoid driving activities that require alertness because some drugs can cause sedation. If there's no relief in diarrhea after 2 days, if there's a fever that's developed, abdominal pain or distension, of course, or blood or mucus appears in the stool, you have to notify the doctor. This could be a sign of another condition. It could be Clostridium difficile or colitis because of the possibility of presence of mucus in the stool. Avoid alcohol and other CNS depressants while taking these drugs. And lifespan consideration, you have to avoid bismuth. It contains aspirin, which can possibly cause bleeding. And for children, infants and children are more at risk for dehydration, so you have to give them enough fluid. For pregnancy and breastfeeding, you have to consult a doctor before starting this medication. And for older adults, since they have a high risk for dehydration, monitor them closely and do not use kaopectate, which is more likely to experience side effects.